Welcome to the Grassroots Health webinar series, Scientists Answer Your Questions. This is Carol Baggerly, and today we have a filmed presentation by none other than our own Dr. Robert Heaney on interactions of vitamin D and calcium. Dr. Heaney's film is approximately 25 minutes, and then he will be online after the film to answer your current questions. Without further ado, Dr. Heaney.
Well, thank you for the opportunity. Carol has asked me to review some of the basics, and I understand that this will be very much a review for some of you, but I think it's important that we all are singing from the same page of the hymn book, basically. And so if this is a review, it's a review, but I just want to be sure we're all together on this. Now, I have no disclosures, and these are the objectives that we had previously listed for this presentation. I want to start with the review of the fact that vitamin D exists in two chemically distinct forms. They're called ergo and cholecalciferol, respectively, or D2 and D3. D3 is the natural form that we find in animals, and it's the form that we make in the skin on exposure to ultraviolet B light. And so I'm going to be talking about D3, but occasionally people will be wondering, well, what about D2? And so here I've just, dealt with it. Serum 25-hydroxy-D is the way vitamin D status is evaluated. The lower end of that acceptable range, as several of the speakers have already hinted, is 100 nanomoles per liter or 40 nanograms per milliliter. Now, the canonical scheme for vitamin D is that the D is made in the skin, it's 25-hydroxylated in the liver, it's subsequently hydroxylated at the one position in the kidney, and that product circulates in the bloodstream and goes to the intestine, where it stimulates the formation of the proteins that are important for the active transport of calcium from our food into our bloodstream. Now, this is basically what we've known for 20 or 30 or maybe even 40 years now. And that's why I refer to it as the canonical scheme. That's what, if you are going to school, you learn in the basics. And as I've already indicated, 25D is the functional indicator of vitamin D status, and it's a principal storage form of the vitamin. You can see that on one of the posters outside, where we've tried to quantify how much of the vitamin D activity in our body is in what forms and where it's located. Now, we've come to understand that that the canonical scheme is not adequate. We need to work with an expanded scheme. The top one is the one that I just showed you a moment ago. It's the endocrine side of the story, and it's 125D circulating in the blood as a hormone going to the intestine to produce a specific effect, as is true for all hormones in the body. But the bottom side is where all the excitement has been the last few years. That's the autocrine side, and what that means is that these products are made internally within a tissue and act locally rather than circulating through the bloodstream. Furthermore, they don't have the kind of feedback controls that you would take for granted with the endocrine side. So we do some 1-alpha hydroxylation in the periphery as well as in the kidney. That's right within the tissues concerned in response to cell-specific signals that will vary from tissue to tissue. Now, the problem that we've associated with vitamin D all these years is rickets or osteomalacia, and that's on the endocrine side of the story. And I'm going to review some of that for you because it's important not to neglect the calcium part of this important hormone. Inadequate concentrations of these minerals, calcium and phosphorus, that are necessary to form bone are behind the problem of rickets and osteomalacia. And furthermore, in the process of the body trying to do something about this, it mistakenly lowers the serum phosphorus level, and that impairs the function of the cells that are responsible for building bone. It's not just that there isn't mineral, but the cells that are responsible for doing it are themselves impaired because they are sick from not having enough phosphorus available to them. This is the type of thing that we used to see a lot of with rickets, bowing of the legs. Here are a couple of other examples, more recent. And you can see the reason for that. The bones are actually bent. They're deformed under the circumstances. much more serious kinds of deformities occur as well. But I do want to call your attention to the fact that in 2008, just 2 years ago, the American Academy of Pediatrics actually doubled the vitamin D intake recommendation for children. And what I'm sharing with you today is the results from a paper that was just published this month in the journal Pediatrics that noted that fewer than 1 in 7 children in the first year of life were given any vitamin D at all. And those who were formula fed did best, not because formula is better than breast milk, but because formula contains some vitamin D. And depending upon the age of the child, from 20 to 37% met the AAP recommendations. Breastfed babies, 5 to 13%, mixed-fed, 9 to 14%. In brief, the vast majority are simply not getting what it is we're talking about. Now, in this particular study, which was based on the infant feeding practices study, 43% were breastfed at least early on, 26% formula fed, 32%. And here is the performance. Look at this. This is the formula fed babies. Here is the target, 100% receiving the AAP recommendation. The breastfed and the mixed fed are just way down in the basement, as you can see. It's just absolutely horrible story. And as I say, published this month, the message is not getting out to the practitioner. This is really a very modest recommendation, actually. It's adequate for the first year of life, but it's not adequate after that. As people grow, they get bigger bodies and they need more. This is a contemporary report this month. Now, we used to think that we didn't have to deal very much, but this is a report from Japan just a year and a half ago showing craniotabes, these bumps on the forehead of this little 5-month-old. These are some of the stigmata of rickets. Fortunately, this will go away when you provide adequate vitamin D supplementation, but we're dealing with problems that are present here today. And that's, this is an example of a pelvis that's been severely distorted by vitamin D deficiency. It's highly likely that a woman, if she'd been pregnant, could not deliver a baby through that. And of course, that would have been one of the factors that led to the paling of the skin as humans moved north out of Africa into Europe, because very rapidly, those who couldn't have babies would not have been able to reproduce. Now, to go back to what's behind all this, it all starts with insufficient calcium absorption. That would tend to lower the concentration of calcium in the extracellular fluid or blood of the body, and that stimulates the parathyroid glands to produce parathyroid hormone, and that then ultimately leads to an increased synthesis of the hormone that's responsible for the active absorption of calcium, and that should then improve that. The problem is, with vitamin D deficiency, you can't do that. And so the whole system hangs up right there. Now, that leads to further falls in the calcium concentration, further rises in parathyroid hormone, and that leads to a further lowering of the renal phosphorus threshold. That lowers the serum phosphorus, which the bones need, and that leads to what's called a calcium times phosphorus product in the bloodstream that's too low to support mineralization. And that's where the problem comes in. If we don't have that, then you can't mineralize the bones and they become deformed as the child grows. And growth itself is stunted because of the damage that the low serum phosphorus causes to the growth apparatus itself. So that's what's behind all of that. So let me look a little bit more at calcium absorption in detail with you. Now, these are complicated slides, but they're important to pay attention to. What I have on this axis is net absorption of calcium as a function of calcium intake on this axis. And all these lines here are derived from actual data. This is active absorption presented as a fraction of the total calcium intake. That's active, that means it's vitamin D mediated. It's what gets across as a result of vitamin D stimulating the formation apparatus. And I'm going to work you through this a little bit here. This would be a typical active absorption fraction, about 16%. Now you see here that at 16% and an intake of, say, 1,400 milligrams per day, you are absorbing slightly more than 200 milligrams of calcium per day from a big intake. That's 1,700, 200 getting absorbed. And if you have a lower intake, say 800, you're not absorbing anywhere near as much. The importance of that 200 milligram line is that's what the average adult needs today in order to offset losses from skin and excreta. So if we're not absorbing 200 milligrams per day, we're tearing down our skeleton in order to get the calcium that we need. And this kind of a nomogram, if you will, allows us to do that sort of calculation. Now, here we are with a typical intake. The recommended intake for individuals over age 50 today is 1,200 milligrams per day, and you see that just hits the 200 milligram per day line. Now, what happens when vitamin D status deteriorates? The active absorption line drops. So now you'd have to have 1,400 in order to meet that need. And if it drops still further, you might need 1,800, until finally, in severe vitamin D deficiency, you'd need, say, 3,000 milligrams of calcium per day in order to get the amount that is required under those circumstances. Realistically, nobody's going to get 3,000 milligrams per day. So you see, there is this strong interdependence. And the bottom line is that in the absence of adequate vitamin D, you cannot absorb enough calcium for health. And so that's why you tear down your skeleton. But equally, all the vitamin D in the world won't help if you don't have enough calcium in your diet as well. So these two actors are playing together in this story. And it's extremely important that we keep both of them in mind. If you don't have much calcium, even 100% absorption is not adequate, because 100% of not very much is not very much. It's just that simple. Now, what we haven't realized until recently is that vitamin D does not cause calcium absorption. I need to stress that. Vitamin D does not cause calcium absorption. It enables calcium absorption. It enables the body to regulate calcium absorption. It doesn't cause it per se. It's 1,25-dihydroxyvitamin D, which is controlled by the body. That's what elicits expression of the calcium transport apparatus in the intestinal lining cell. But we've only just recently realized that you have to have both molecules, both 25-hydroxy-D and 1,25-D, must be present for the enterocyte to absorb calcium adequately. And the evidence for that is that we do not see hyperabsorption in outdoor summer workers, despite the fact that they have high blood levels of 25D. It doesn't cause calcium absorption. And similarly, in patients with nutritional rickets or osteomalacia, we don't see absorption of calcium at all, despite often high levels of what we think is the responsible hormone. It's 125D. The problem is you have to have both of these hormones. You got to have 125D and 25D present for the enterocyte to do its job. And if you don't have one, it's not going to work. If you don't have the other, it's not going to work. So we need both. And that's why keeping an adequate blood level of 25-hydroxy-D is important, not just for all of the other effects which we're going to be talking about the rest of the day, but it's important also for the calcium side of the story as well. Now, how much is adequate in terms of absorption? Here are some data, probably the only data in the world that'll look seriously at the relationship between serum 25D and calcium absorption fraction. And you see here that we've got two sets of studies, this one from my laboratory, this one from another group. And you see that absorption fraction rises as vitamin D status improves. And doesn't take a lot of imagination to see that there's kind of a threshold effect there. Now, it would be logical to think, well, hey, you just said that this doesn't cause calcium absorption, but it sure looks like it's causing calcium absorption there. But what's happening is that when you give vitamin D to people who are calcium deficient, then they do improve calcium absorption. But if they have plenty of calcium, then they don't. And that's shown by the fact here that the body is perfectly able to up and down regulate calcium absorption once you give it plenty of vitamin D. So it can go way down to low levels, it can go way up. It tries to regulate down here as well, but it doesn't have as much room. So think about vitamin D as an enabler. It's It's what the body needs to do whatever the specific job is. We'll see a dozen examples of that through the day as we go from tissue to tissue to tissue. Vitamin D isn't causing any of the effects. It's simply enabling the body to deal with whatever the current stresses are. It's a part of the apparatus the body has to have in order to do that. Now, I'll spend some time going through that mechanism this afternoon. Now, I want to go through some of the studies that would back that up. For instance, in a study we published several years ago, we raised serum 25-hydroxy-D from 50 nanomoles to about 80 nanomoles per liter, and we measured calcium absorption under the circumstances, and this is what we found. That absorption fraction went from about 22% up to around 37%, simply by raising the vitamin D status from 50 to about 80 nanomoles per liter. That was a very substantial improvement in calcium absorption. Now, the reason why we originally published 80 nanomoles as the level that was needed to enable calcium absorption fully was that's where it seemed to plateau for us. Now, for other effects, we're going to find plateaus at different levels. So there's nothing magical about 80. It just seems to be that's where it is. If we step through this a little bit, there's the calcium absorption effect, but we measured other components of this process. The serum calcium went up as well, as you can see here. This is all within the normal range, and a physician would never notice this because it would come back in the normal column from the path lab, so you wouldn't pay attention to that. But it's a physiological effect, and it's doing exactly what you would expect it to do. And similarly, the parathyroid hormone level dropped as well. So that all the pieces of the puzzle were acting just precisely as the model said it should. Not all of my experiments turn out that neatly, but this one did. Similarly, Heike Bischoff, in a study of the data from NHANES, the National Health Nutrition Examination Survey, which has been ongoing now for 40 plus years, sees this kind of an effect for bone mineral density as a function of serum 25-hydroxy-D level in the population. The top line being for non-Hispanic whites, the middle line being for Mexican Americans, and the bottom line being for Hispanics. And you see bone mineral density, at least in the non-Hispanic whites, never does plateau. I mean, up here as high as 150 nanomoles per liter looks to be a better situation than down here even at 80 or 100. And to a substantial extent, that's true. Nobody would want to be below 80 nanomoles per liter by these kinds of standards because there is a disadvantage to being down there. This is an important study published several years ago in the British Medical Journal, a 5-year randomized trial of vitamin D supplementation in healthy British adults, raising serum 25D from 53 to about 75 nanomoles per liter. Not where we would like it to be, but that's what the study did. And even that was sufficient to lower the risk of osteoporotic fracture, hip, forearm, and spine by 33%. Hard data, level 1 evidence, randomized controlled trial. Now, that's not the only set of data of that sort. This is a series of such trials with anti-fracture efficacy as the endpoint. And it shows an important point that the level of 25-hydroxy-D we can achieve in the patient is important in determining the results. If we give such a low dose that we don't achieve much of a level, we don't get an effect, hardly surprising. But it takes levels above 100 in order to be certain that you're absolutely getting an effect there. So here's another piece of evidence pointing to a level of 100 as being as low as you would want to go. There are questions of safety that I was asked to address. This is a batch of 33 men, average age 39, who were dosed at a rate of 5,000 to 10,000 international units per day, every day, from October through February. And this is what happened to serum calcium. There was, the serum calcium, if anything, fell a little bit over this period of time. There was not a single instance of hypercalcemia. This happens to be beginning and end, but we followed the serum calcium every month, and there was no rise above the upper limit of normal. So again, that's one indication of safety. So in our experience, doses of 5,000 to 10,000 for 4 to 5 months do not elevate serum calcium, do not elevate the urine calcium. And furthermore, it's important to understand that those kinds of doses produce levels that are frequently found at the end of summer in outdoor workers. And in those outdoor workers, as I've stressed, we do not see hyperabsorption of calcium. Now, here's one such example. This is what we got at the end of summer in a batch of outdoor summer workers with values up above 200 nanomoles per liter. But notice there's a huge amount of variability from person to person. Some people do not get up even to a healthy level at the end of summer in Omaha, Nebraska. And it's a fairly sunny part of the world. But everybody falls, and by the end of February, you're down, the average is below 80 nanomoles, and there are very few people above 100. So there's a need for supplementation, you see, under these circumstances. These are the same individuals, of course. Now, I want to refer to a brief paper on toxicity that was published now just 3 years ago. This is a log scale here, so we're starting at 1,000 international units per day going up to 10 million. I'm not recommending this, please understand that. And this is serum 25-hydroxy-D. These red circles are the means of 15 studies of controlled vitamin D supplementation in which we were working out the pharmacology of this potent compound. And the triangles here are 8 studies that reported individual cases of toxicity. I'm highlighting them in orange so you can pay attention to them. Now, the important point is these are people with toxicity, but notice the doses that are required here. There's no toxicity below 500 nanomoles per liter or 200 nanograms per milliliter, and no toxicity in reported cases at intakes below 30,000 international units per day. Be a rare individual that might need 30,000, 1 in a million, I don't know. It's not what the everyday person kind of needs, but it's important to know that there is safety in this range here. Kidney stones are a problem that keep cropping up, and the reason for that, I think, is that people tend to think, well, vitamin D causes calcium absorption, and if you absorb more calcium, you're going to have to put it out in the urine, and that'll cause kidney stones. And I've tried to stress to you that isn't true. Vitamin D doesn't cause calcium absorption. It enables the body's regulation of calcium absorption. And I'm going to show you some data. These were reported recently from the Women's Health Initiative. This was the kidney stone risk per 100,000 population, and it was over 300 individuals per 100,000 population per year. And in the placebo group in that same trial, there was a slightly lower risk. And this got a lot of publicity, and that led people to worry about whether there was kidney stone risk. Now, on this scale, I put a number of other studies, and I want to show those to you, but I want to stress that the stones in WHI were self-reported. It was not a pre-planned outcome variable, and the outcomes were never adjudicated. We don't know, nobody looked at the record, nobody got the medical record to see what really happened, so we don't know. And the vitamin D dose achieved was only 200 international units per day. Now, if that is causing kidney stones, then I ask you. I pulled together in this publication, I pulled together all of the published calcium trials. And I looked at the reported kidney stone risk in those calcium trials. You know, just giving older women calcium to see what would happen to their bones, basically. And you see, the placebo group in all these trials had, if anything, a slightly higher kidney stone risk than the calcium people, but essentially the same number. So there was no role of calcium there. And when we look at the epidemiological data from Olmsted County, Minnesota, and from the Nurses Health Study, we're looking at relatively low stone risk, below 100 per 100,000 patients per year. Now, what was going on in WHI, nobody knows, but I think you have to, I mean, any experienced epidemiologist would say there's something wrong with these numbers. In brief, WHI stone numbers are so far out of line with all the other stone data available in the US that they can't be accepted as real. And nor could they plausibly be attributed to the tiny dose of vitamin D that was achieved in WHI. Now, I do want to show you where we stand right now. This is a frequency distribution for serum 25-hydroxydese in a semi-rural population in eastern Nebraska, and it's nearly 1,200 women, as you see here. Fits a Gaussian curve very, very nicely, as a matter of fact. That's the mean there, and here we see this level of 80 nanomoles, which is where calcium absorption gets optimized, and here's where 100 nanomoles would be. And if you just even take 80, you've got 65% of this population getting moderate sun exposure, having inadequate vitamin D levels. And if we were to use a standard of 100, it would be much worse. This publication from the journal Pediatrics just last fall shows exactly the same phenomenon, but these are for children, non-Hispanic whites, non-Hispanic blacks, and Mexican Americans. These values in the peach colored are below the lower end of the reference range for NHANES, and those in white are below 30 nanograms per milliliter. Not 40, but below 30. Look, 98% of black teenage girls below a minimally acceptable level in the United States today. Not all that much better for Mexican Americans or for Caucasians. The younger children tend to do better, but still 40% is totally unacceptable. I just have to sum up by saying that all studies in virtually all nations, irrespective of latitude, show that the majority of the world's population has an inadequate vitamin D status. And so to wrap up, vitamin D deficiency is a worldwide problem, all ages and races, and alarmingly, rickets, classical rickets, is on the rise today. It's a totally preventable problem. Never should be allowed. Prevention and treatment are inexpensive and easily implemented. Serum 25D needs to be above 40 nanograms, as is commonly found in people who are outdoors a lot. The needed total vitamin D inputs, I think, can be succinctly summarized as 75 units per kilo per day. That applies to all ages and all body sizes, so that covers the problem of obesity as well. And with that, I thank you.
All right. Dr. Heaney, thank you very, very much for that presentation.
Hi, Carol.
Hi. Thanks so much for that presentation. It was great.
Well, it was a couple of years old, but I think it was still accurate.
Based on the questions that we have, I think it's still very, very much needed. I wanted to make a comment about kidney stones. In one of your slides there, you talked about kidney stones, and I wanted to alert people to the fact that we have a paper that's, many of the people on this line are actually participants in the Grassroots Health study, and we are getting ready to publish a paper showing that there really is essentially no effect on vitamin D levels on kidney stones. As a matter of fact, there seemed to be a slightly higher level of kidney stones with people with lower vitamin D levels. And thanks to everyone's participation, that should be out very soon. I'm very, very excited about that. Dr. Heaney, on this particular set of questions right here about levels and dosage, I think you pretty much addressed most of these in your presentation, but if you would like to just kind of quickly take a look at the list of questions there, because they all kind of go together, and summarize your answers, as it were, to the questions that are there.
Sure. Let me just run down very quickly. The
Sure.
first question has to do with the safety of 10,000 international units per day. The Endocrine Society of the United States issued a set of guidelines for practicing endocrinologists just almost 2 years ago, and they designated 10,000 IU per day as a safe intake for everybody. They didn't recommend that much, but they said it was safe. And I can't think of very many situations where 10,000 might be required, but as I've said, it's safe. Now, does the calcium level increase with a higher 25-hydroxy-D level? The answer is yes and no. The yes part is yes, it does go up, but the amount is too small to be detectable except in a research context. The average clinical laboratory, the average blood test your doctor would get for calcium couldn't pick it up. So it's quite small, but it's real. Third, can you cause an imbalance of calcium by taking too high a dose of vitamin D? And please explain the mechanism. Well, no, you can't. There isn't. I'm not even sure what an imbalance would be, but if you take, well, what would be too high a dose of vitamin D? Say 10,000 international units per day, as in the first question. Would that cause any kind of a problem for calcium metabolism? No. And the reason for that is once the body gets as much calcium as it needs, it stops absorbing calcium from the food, and the vitamin D won't force that. The body uses the vitamin D to make this hormone called calcitriol, which is what's responsible for stimulating calcium absorption from our food. But if we've got enough calcium already, the body doesn't make it. So the vitamin D is available for other body functions, but it's not being used to promote calcium absorption. Fourth question, how much calcium should I take with vitamin D3? This person takes 5,000 units. Well, how much calcium you should take depends upon how much your body needs, and there isn't a single answer there. We can recommend about vitamin D because modern humans get so little from the environment, from food and sun, that we know that we have to supply it in the form of supplements. But the right way, the best way to get your calcium is in the form of food. And the dietary guidelines for Americans for the last 10 or 15 years have recommended 3 servings of dairy food per day for everyone over age 9. And I have to strongly reinforce and encourage that kind of a high intake. Now, the reason for that is that the dairy foods contain the other nutrients the body needs in order to have bone health, in order to utilize the vitamin D effectively. And if you just take a calcium supplement, you don't get any of those other nutrients, some of which couldn't be put into a supplement tablet even if you wanted to. So please do emphasize getting as much of your calcium as you possibly can from food sources, preferably dairy. If you don't make up to the recommended intake levels of, say, 1,200 to 1,500 milligrams per day from diet, then you can supplement with a calcium supplement tablet. But do bear in mind that you still may be missing out on some key nutrients. You can make up for the calcium deficit, but you won't have made up for the other nutrients that might have gone along with it. Now, you might immediately ask, well, what are those nutrients? Why can't I take them too? Well, they differ from person to person. It depends on which foods you're not eating. It's just that simple. So the safest way is to maximize your dairy intake as best you can. The fifth question, should my calcium and vitamin D intake be more if I have osteoporosis? And this person, again, takes 5,000 IUs per day. Well, I think the requirement for people with osteoporosis is probably no different from the requirement for people without osteoporosis, and that is we all ought to have a calcium intake in the range of 1,200 to 1,500 milligrams per day, and we all ought to have a 25-hydroxy-D level of at least 80 and preferably above 100 nanomoles per liter, which is 40 nanograms per milliliter. But if you have osteoporosis, then you've got to focus on bone, and maybe your motivation to do something about it is better. It's not that the need is greater, but you surely do need it then, and the amount should be about the same as for everybody else. The sixth question in that list is, have you observed any adverse effects with maintaining a stable 25-hydroxy-D of 80 to 100 nanograms per milliliter with all cofactors, whatever the cofactors might be, I'm not sure. No, I'm not aware of any adverse effects. As I said in that one slide I showed you with the cases of intoxication, there have been no reported cases of intoxication below 200 nanograms per milliliter. And so a level of 80 to 100, while it's probably higher than you need, is nevertheless safe. So that's it for that list of 6 questions, Carol. First of all, question 7, recommended intake levels of vitamin D are way too low. Is that also true with calcium? Probably. the primitive human calcium intake was probably, for people of contemporary body size, would probably have been up in the range of 2,000 to 3,000 milligrams per day. And the current recommendations are 1,000 to 1,200. So yes, I think they probably are too low. There's a real challenge because, as I've said, you need to get it for food where you can. And with today's limited lifestyles, that is, we're not doing hard physical labor, men and women, all day long, as would have been the case with our grandparents or great-grandparents. You don't have to go back into the Dark Ages. Just earlier in the 20th century, people worked a lot harder physically than you and I do, or at least than I do. And so for that reason, you can't afford to eat a lot. That is, 2,000 calories per day is probably more than many of us can handle. And it's hard to pack in a lot of calcium in 2,000 with a diet that's just 2,000 calories per day. So yes, I think the recommendations are too low, and what we can do about it is, I think, a challenge that we don't have a final answer to. Next question, if vitamin D levels are within normal range and calcium levels are low, what are the symptoms? Well, we haven't defined what normal range and what low calcium is yet here, so this one is hard to handle. But if vitamin D levels are normal, that is above 40 nanograms per milliliter, and your calcium levels are low, you probably won't have very much by way of symptoms, except you may have brisk reflexes, you may have some stiffness and soreness, you may have some constipation. There are a number of other problems that may happen, but they'd be very nonspecific. I don't think that we would find any particular symptoms there. Now, question 9.
Dr. Heaney,
Yes.
is there a specific recommended range for a calcium level?
The normal calcium level measured simply on blood serum without any special treatments will be in the range of 9 to 10 milligrams per 100 cc's of serum, 9 to 10, averaging about 9.5. And some labs have a normal range that extends down to 8.8 and extends up to about 10.3, but it's going to be centered somewhere in the mid-9 range. If you have a low serum calcium, that could be simply because you have a deficiency of protein. You're malnourished, because a lot of the protein in the blood binds calcium, and if you have less protein, then you're binding less calcium, and so the total calcium concentration seems lower. But there is something called ionized serum calcium, excuse me, which is what the cells of the body see and want to see, and that is measurable in a laboratory, but it tends to be a research procedure, and so that's why I answered the question for total serum calcium, which is what people are likely to have measured.
Thank you.
Okay. Question 9, calcium supplements are augmented with vitamin D3. Does taking other D3 sources off balance the overall mineral vitamin ratios? No, there is this kind of funny idea about balance that people have, that you need to take a certain amount of this if you're taking a certain amount of that. I don't know of any balance receptors in the body. I don't know of any way the body would be able to sense that. If you're deficient in both vitamin D and calcium, you want to fix both of those deficiencies. The nice thing about the body is if you're getting more than you need, it doesn't use it, except for calories, and there it stores those in the form of fat, unfortunately. But I'm not worried about balance, and I would urge you not to be either. Question 10, I'm totally confused about supplemental calcium. Reports show it can cause calcium buildup in arteries, so I stopped taking it. Is this true? Well, if you stop taking it, I guess that's true, but of course, does calcium build up in the arteries when you take calcium supplements? The answer is no, definitely not. There were some studies that reported that starting about 4 years ago, but they have been thoroughly refuted by half a dozen different, very large, very rigorous papers showing that there is no risk of that, and that the papers that reported it were in error. That is, they made some mistakes which caused them to come up with that conclusion. So by no means should you be concerned about calcium buildup in your arteries. Now, if you want to look into that a little bit further, for whoever asked that question, I can refer you to a blog that I have created, and you can get access to that from the Grassroots Health webpage. I deal with that question of the calcium scare, and you can get more detail there if you'd like. Question 11, is calcium valuable or not for bone strength? The answer is, it sure is. You put animals on low calcium diets and they break their bones. You put humans on low calcium diets and they break their bones too. It's just that we don't see it quite so obviously as we can with an animal. You can't have bone strength if you don't have enough mineral, enough calcium to give you the strong bones you have to have. So anybody who says that dairy products or calcium is not valuable or does not produce bone strength has a different agenda. They're trying to confuse you because they don't like something else you're doing, basically. Are there ethnic differences in vitamin D and calcium mechanisms? Well, there are ethnic differences in everything, but there aren't big differences with respect to vitamin D and calcium. The bones in African Americans have less dependence on vitamin D than do the bones in Caucasians, but they both have a dependence. It's only a quantitative difference. Do both need the same amount of vitamin D? Yes, but African Americans don't get it so readily because, one, they have a natural sunscreen built into their skin. Their skin pigmentation blocks the sun's conversion of the precursor into vitamin D in their skin. And secondly, they tend not to drink much milk, which is a fortified source of vitamin D for our diet. So they don't have a greater need, but they don't get as much, so they need to take more in order to get up to the same level as everybody else. And that's it for those 12 questions. You said you had some extra ones? Question 8 is, I'm dealing with serum calcium that runs high, 10 plus. Well, what should I do? And again, we can't practice medicine over the telephone this way, but it could be simply that you're one of the people on the upper end of the Gaussian distribution, the normal curve, and that your calcium is normally 10.2 or 10.3, and that's perfectly fine for you. But it's more common, particularly if you're an older woman, that you might have overactivity of the parathyroid glands. What's called primary hyperparathyroidism is relatively common in postmenopausal women. It tends to be mild, and when that happens, you'll have an elevated serum calcium. And you need to talk to your physicians about that to see if they can figure out what might be going on. Doesn't mean you have to do anything to treat it, but still, if it's abnormal, you want to check it out. Question 9, what's the appropriate reference range for the calcium-creatinine ratio to judge someone as hypercalcemic? Or is that even the appropriate measure? Well, the calcium-creatinine ratio is the amount of calcium in the urine, and hypercalcemia refers to an excess of calcium in the blood. And so they're not interchangeable in any way. You would have a high calcium to creatinine ratio if you were hyperabsorbing calcium, if you had a disorder that caused you to absorb calcium beyond the body's controls or needs, or if you were tearing down bones, such as with a bone disease, cancer with metastases to bone or spread to bone, that can sometimes cause an elevation. There are several things that can cause this, of course, and the measure does change with age. During rapid growth, it's uncommon to lose very much calcium in the urine. You're putting as much calcium as you can into your bone because you're growing. But for older individuals, it tends to be constant. And the There is no single number I can give you because it depends on how they measure the calcium and how they measure the creatinine, and each lab does it differently. So you'll have to get the lab normals in order to find what the upper level is. Okay, the other vitamin D questions. 10. What is the current thinking on how long vitamin D levels stay in muscles, fat, tissue before they're too low? Well, the current thinking is that the amount of vitamin D in your tissues is closely related to the amount of vitamin D in your blood. And there are two forms of vitamin D, as I stressed. The first is native vitamin D itself, cholecalciferol. That's what we make in the skin. That's what we take in a supplement. And when we swallow that, it goes immediately, or when we absorb it through the skin, it goes immediately into the bloodstream, and it gets immediately distributed in all the other tissues of the body, including fat. It's a fat-soluble molecule, and so it tends to go readily into fat tissue because it's comfortable there. But it'll be in the blood as well, and it'll be in the other tissues as well. Now, how long does it stay there? Well, we measure that with something called a half-life, and we have half-life data for 25-hydroxyvitamin D, but we don't have easily interpretable half-life data for vitamin D3 itself, cholecalciferol, in the body. We've got just some anecdotal data, but for 25-hydroxy-D, the half-life generally ranges around 3 to 4 weeks. That is to say, if you had no other 25-hydroxyvitamin D coming into your body and you weren't making any more, 2 or 3 weeks from now, you'd have half as much in your blood as you did when you started. So it's constantly being used. We found in a study in which we gave 50,000 international units a week for 12 weeks, and we measured the vitamin D content in the fat both before and at the end of that 12-week period. We found that the average utilization of that 50,000 a week was about 85–87%. So it wasn't being stored at all, except for a small fraction of it. It was simply being used. The body needs vitamin D. It needs it every day. If we were living under ancestral conditions in equatorial East Africa, we would probably be making 10 to 15,000 international units per day, every day in our skin, and we'd be using much of that. So under those circumstances, the amount in the tissues would remain constant because we were replenishing it from our skin synthesis as fast as we used it up. Okay, question 11. A physician and an ND, a naturopathic doctor, has said that high doses of vitamin D can cause hypercalcemia. That 50,000 international units can cause accumulation of calcium and use up all magnesium. Is this true? Well, high doses of vitamin D can cause hypercalcemia, but it takes doses well above 30,000 international units per day. And typically, that doesn't happen until you get a blood level above 200 nanograms per milliliter. So the answer is yes, but you have to go to a lot higher levels than we would recommend. That problem is called vitamin D intoxication. Now, does it cause accumulation of calcium? Well, yes, if the serum calcium rises, then serum calcium, the calcium in the serum can precipitate out in various tissues. Now, there isn't any question of using up magnesium. Magnesium is a metal and doesn't get used up. So I don't even know what that question could mean. And we're not recommending 50,000 international units per day. A single dose of 50,000 international units wouldn't do anything. You'd have to take it for a long period of time, or even that, to increase your risk of hypercalcemia. Carol, you had asked earlier what the mechanism for the hypercalcemia might be. Well, it's poorly understood, actually. We have mistakenly assumed that the hypercalcemia is produced by absorbing too much calcium. But what we've found is that it occurs even if you don't absorb any calcium at all. So something else is going on in the body. And the most likely explanation is that we are changing relationship between blood and bone so that the bone mineral tends to support a higher serum calcium level just by physical dissolution. There's an equilibrium between the blood that circulates past the bone and the bone itself, which of course is very rich in calcium. And we suspect that's where the problem's occurring. But it's not because of hyperabsorption of calcium. As I've said, there isn't any hyperabsorption of calcium from vitamin D alone, even at 50,000 international units. Next question, what is a proper vitamin D and calcium with magnesium ratio? That's a balanced question again. There isn't any ratio that I know of. You need enough magnesium, you need enough calcium, you need enough vitamin D. Get the recommendations and you'll be okay. Preferably get them all from food, except of course vitamin D, where we know we can't do that. We normally got that from the sun, but we're not getting it from the sun anymore. So get the recommendations and forget the ratio. Question 13, what effect does calcium and vitamin D have on physical activity, endurance, and strength? Well, basically both have a positive effect on all of them, but they're small. We've been concerned in recent years with athletes and doping. And none of us is old enough to remember back into the days of the Olympics in the 1930s when some nations were accused of doping their athletes by giving them extra vitamin D. And it's possible that improved their timing by a second or something of that sort. So there are some likely effects, but they're small. And there's no evidence that getting more than you need has any benefit. This is like everything else. Get enough vitamin D and you've got its benefits. Taking twice as much won't give you any more benefit.
Thank you. On the next set of slides, the most absorbable form of calcium and magnesium for a 70-year-old female. I hope it doesn't matter too much whether you're a 70-year-old female or somebody else, but sorry.
Well, instead of absorbable, I'm going to say utilizable.
Okay.
Because dairy foods and green vegetables and calcium supplements are all absorbed to about the same degree, a few percentage points one way or the other, not much difference. But the point of getting calcium with dairy is that you're getting the protein you need to make bone as well. You're getting the riboflavin, you're getting the magnesium, you're getting the potassium, you're getting B12, you're getting a whole array of nutrients that are necessary for your health. So optimize not on a pill. The various supplement manufacturers will advertise their pill is better than somebody else's pill. Nobody's pill is as good as food. And the best pill, when you have to resort to pills, is the one that you can take regularly and that won't break the bank. And I tend to recommend the brand name big pharmaceutical house supplements. Their reputation rides on doing it right, and they tend to know how to do that. What
Dr. Heaney, we are going to zip through the remaining questions. I don't want to necessarily shortcut anything too much, but we've got about 5 minutes, and I want to get through the rest of these, or at least pick a couple that you think are really critical.
Okay, good. I'll go to 16. Shouldn't we be getting our calcium from green veggies instead of dairy foods? No, green veggies are wonderful foods. I eat lots of them, but they don't provide me with the protein and some of the other nutrients I need. So there isn't a good way in a modern diet to get everything we need without dairy. You'll notice that the dietary guidelines for Americans increased their recommendation from 2 to 3 dairy servings per day, and there's some discussion of going to 4. And that's not because of the calcium, although that's important. It's because they had trouble getting a fully adequate diet with respect to all other nutrients if you don't have dairy. If you've got some objections to dairy, or if you're concerned about lactose intolerance, once again, I would refer you to my blog where I've got an article on that point that will allow you to think that over and go into more depth there. Let me look very quickly at these others. If the parathyroid gland's been removed, how much vitamin D should one take? That's a medical question. I strongly urge you to talk to your doctor about that, because here, and we've been talking about calcium and vitamin D as nutrients. When you've got hypoparathyroidism, because your parathyroid gland has been removed, you've got a medical condition, and anything you take there is going to be a drug, not a nutrient. So we're not going to talk about that. Does the normal 25-hydroxy-D vary according to level of calcium intake? You bet. If you have a very high calcium intake, your parathyroid hormone level will be appropriately low. Not low in terms of being abnormal, but low because that's how the good Lord made our bodies. The parathyroid hormone is there to help keep our blood calcium up, and if it's already up because we have a very high calcium intake, then the parathyroid glands can coast. They don't have to work as hard. I think that uses up the time, Carol.
Thank you so very, very, very much for a very, very exciting and informative session, Dr. Heaney. We always appreciate your contributions. And for those of you who have listened throughout and everybody stayed online, Dr. Heaney, you had a record attendance today, I tell you. Next time, we will have Dr. Hollis, Dr. Bruce Hollis, talking about vitamin D requirements for breastfeeding mothers and infants, which I think you may recall Dr. Heaney even speaking a little bit about today. Dr. Hollis is coming back and will be presenting the same set of slides that he just is presenting this last weekend at the a pediatric conference up in Washington, D.C. So I hope very much that you will tune in again next week. And we also encourage you to help sponsor these beautiful webinars. We encourage you, first of all, to join our D-Action project, to test and share your data with us twice a year over periods of time, and any other way that you can think of. Spread the word, and again, thank you, and we will see you next week. Bye.
Bye.